Okay, everyone, it is 1:01 and we have a lot to cover, so I'm going to get going. As I said at the top, this is going to be recorded, and the slides and the recording are available online, where the links will also be with you. We will also have somebody available to drop some of the links in the chat as we go, in case you want to look at the resources as we talk about them. So the first thing that we're going to discuss is the additional doses and the booster doses that have been in the news recently. So to start with the additional doses, we do have some CDC resources that were shared by email with all of you. The EUAs for both Pfizer and Moderna have been updated and are posted. There currently is insufficient evidence to advise the additional doses for the J&J, so the additional dose is really just for the mRNA series. The interim clinical considerations have also been updated. The clinical considerations in particular are going to be a good resource to answer your questions, specifically around timing or the specific population that this guidance applies to. The CDC has also created a couple new pages. The first one is appropriate to share with your patients, and it includes a brief FAQ as well as a really good, concise overview of this update, the new recommendation. The second one is specific to talking with your patients about this new change and their own immunocompromised condition. There was a COCA call on the 17th, this last Tuesday, in which this was recorded, and the slides are also available online. The call is effectively an overview of the ACIP meeting, which occurred on the 13th. So if you're interested in seeing the full presentation of the data, that's available as well through the link on the slide. I've also included just the media statement about the update, as well as a link to a presentation that really goes through nicely the data that informed this change. So moving on to talk about the booster doses, which were announced just yesterday. I've included the full joint statement here with a short excerpt on the screen, but essentially the statement says that though the vaccines have proven to be extremely effective, there is now data that supports a reduction in protection with time. The FDA and the ACIP are still reviewing the data, and so there's currently no recommendation for additional doses beyond the primary series for any but the additional doses that we covered for the severely to moderately immunocompromised. The statement notes that the anticipated rollout for these boosters would be around September 20th. And the booster would occur 8 months from the second dose. The healthcare workers and the long-term care residents were the first groups to be immunized initially during the rollout, and so these will be the first groups to receive the booster. Similarly to the additional dose recommendation for the immunocompromised, there isn't enough evidence to support the additional dose of J&J, though it is anticipated that with more time, a similar recommendation may be made. This next slide just includes 3 MMWRs that came out yesterday, which contain a lot of the data that informed this updated planning. So just to go back to the additional doses for a second, for those of you that are looking to administer this additional dose to your population, you are free to do so. It is a self-attest from the patient, and they do not need to show you any proof of a condition. You should use the vaccine out of your existing inventory and order more vaccine as needed. The clinical considerations say that the additional dose should align with the primary series, but if that is not available at your office, you may administer the other mRNA vaccine that is available. However, if you do wish to order a different mRNA vaccine to serve your patients, you're welcome to do so. There should be a HAN coming with a little bit more information about this and some more specification for Vermont. And so with regards to booster doses, a lot of estate planning is happening around getting ready for this mid-September booster dose. As information on the planning becomes more available, we'll make sure the immunization program will make sure that we are communicating all of that to everybody on this call. We are hoping that the TVRS system will be available, and there are a lot of people doing a ton of work to get that system ready for that time. We also just want to acknowledge that these booster doses will be likely to occur right at the height of flu season, and that you may have some concerns about your capacity. And just letting you know that more resources will be coming about these booster doses. Before I move on to the rest of the agenda, are there any questions about the booster doses and the additional doses?
This is Devin. I just want to clarify. So you said if you should try to match someone up, like, so if someone was Pfizer, you should try to give them Pfizer, but if you don't have Pfizer, you can give them Moderna?
Yes, that's the way that it is worded in the interim clinical considerations. I think that might have been put in the chat. Yes, and you are able to order the other vaccine if you prefer.
Thank you.
There's also a question in the chat of should they sign a waiver claiming that they qualify? And Margaret, would you like to answer that?
Yeah, so the health department is just following CDC's recommendation that patients self-attest, that we don't require any other form of verification for this. But ultimately, it's up to your practices to make those choices.
And so that addresses another question in the chat of local pharmacies asking for a physician order for a booster. Margaret, that's their right to do so, right?
Yes, it's been brought to our attention that Kinney Drugs is asking for a prescription from a doctor before administering the third dose to the immunocompromised individual.
And sorry, Lauren, I cut you off. Is there something you'd like to add?
I was just kind of following through with the waiver one. If the clinic felt more comfortable having patients sign a waiver saying, yes, I qualify or whatever to these conditions, that we'd be allowed to do that. Like, that's not violating anything.
Yep, that's entirely your practice's decision.
Okay, great. Devin, you put your hand up?
Yeah, so you said, so it is okay for a place like Kinney Drugs to go further than self-attestation and require a physician's prescription?
We would rather that they weren't, but it's their, they can choose to do so, yeah.
Okay, and then for hospital clinics, it sounds like you prefer self-attestation. Do you have anything that you're requiring for hospital clinics? I understand that you don't have like a lot of control over the pharmacies. I guess I just want to clarify that for hospital clinics, it should be just self-attestation.
That's what we're recommending, Devin, but yeah, we're not requiring one way or the other at this time.
Okay.
Thank you, Margaret. There was one quick question in the chat about, are we still ordering only on Wednesdays? And Karen, do you want to just answer that quickly?
Yes.
Oh, you did it. Yeah, sorry. I didn't scroll all the way down. Thank you. The answer is yes. Are there any other questions around the booster doses or additional doses before I move on? Okay, great. Feel free to, if something pops in your head, feel free to raise your hand or put something in the chat.
Can I ask one more question? I'm sorry.
Yeah, don't worry.
I know you already said we could give one mRNA or the other, but would you really like us to try very hard not to do that? Or does it not really matter?
I'm going to let Margaret answer that one because I know that it is a like a balance between those two.
So the CDC recommends that you stick with the same brand of mRNA vaccine as much as possible because there hasn't been any safety studies done on getting mixed doses of the vaccines. So there's no way to know if there are anything at this point. So that's why they recommend, whenever possible, to stick through the series with the same brand of mRNA vaccine. There are some cases, I know, for at least for our public clinics from the health department, and I'm sure for you as well, where you can't figure out exactly what brand they were given initially. In those cases, you can give whatever mRNA vaccine you have available, but you should take steps to try to find out that information as much as you can. You can check the immunization registry. It may be in there if someone doesn't have their vaccine card with them. But if you have to and you have no idea, we don't want to miss the opportunity to vaccinate somebody. And CDC does allow, if you don't have any information on what they got initially, you can give them the mRNA type of vaccine that you have available.
Thank you very much.
And we had previously advised that practices only order one of the mRNA vaccines to avoid confusion. But if you anticipate that your office is going to have some of these patients that are in need of this additional dose because of a severe or moderate immunocompromised condition, you are free to order and carry and manage both of those vaccines. Do you have anything you want to add about that, Karen, about any considerations if they choose to do that?
No, nothing to add.
Okay. So just to move on, so we, in addition to additional doses and booster doses, we are also in the planning mode for the 2 to 11 approval. We sent a survey out to all of the pediatric and family medicine locations in the state, and we've received it. It was due yesterday, and we received the survey back from most offices. So thank you so much for those of you who have finished it. We also are really happy to see that many of your offices are already thinking about this age group and creative ways of serving them, whether it be night hours or weekend clinics or additional staffing. So that's great to see. I also want to put a plug in that the survey hasn't closed. It was due yesterday, but we haven't closed the survey online. So if you haven't completed it, it would be great if you did. It really will help us with our state planning for this age group to know what the capacity of your office may be. If you need that survey link sent again, you can just drop something in the chat and I'll make sure that it gets sent to you. Just a little note about the availability of the J&J vaccine. Currently, we have a very low availability from the vaccine depot. We anticipate more allocation possibly in September, but we haven't received a confirmation on that yet. If you do have a really specific need for J&J, don't hesitate to reach out to us. We may have it available for a clinic you're planning for a specific population. You can just email the program and somebody will get back to you. Pfizer, we received notice that the Pfizer expiration dates are likely to be extended specific to the ultra cold. So only Pfizer vaccine that is currently stored in ultra cold will have an extension of the expiration date. This isn't finalized yet, but it is expected that before the first expirations at the end of August occur, that the extension will take place. And so the anticipated extension, what was submitted for review, was moving from 6 months expiration to 9. So we're expecting an additional 3 months to that close to expiry Pfizer vaccine stored in ultra cold. And a communication will go out widely about that once it is confirmed. So we are right against flu season, and so Karen wanted to just say a couple brief things. A lot of you on this call are also going to be managing flu vaccine. Karen just wanted to say a few things about this upcoming flu season and the ordering.
Good afternoon. The immunization program receives multiple allocations of several different flu vaccine products throughout the late summer and fall. And typically in the early season, we order flu vaccine on your behalf and estimate what we believe you'll administer in the first month based on our availability of vaccine at that time from our allocation. And then after we have a decent supply allocated to us, we turn the vaccine ordering process over to practices to order yourself. But this year we're going to change the process a little bit, and we'll start out with practices ordering themselves, which we think will be better for you to have more control over that. So beginning September 7th, practices will be able to place orders in VIMS on your own. What you should plan for now is to estimate your need for about 3 or 4 weeks, what you would be able to administer, but not to exceed about a quarter of what your seasonal need would be. Because we believe that would be about what our allocation at that time will be. If you don't intend to administer flu vaccine in September, you don't need to place an order on September 7th. Or if you want to wait a week, you can. That's just the first date. There will be more details about how to place the order and how to reconcile in VIMS coming up in the next couple of weeks. But wanted to give you a heads up that everything's in the works for that to happen, and we'll send more information in the future.
Thanks, Karen. And then just sort of piggybacking on the flu, there is, and someone put this in the chat about financial arrangements to help with these flu and COVID clinics. We are exploring a funding option really similar to what was available last season through the AAP, where you could apply for grants for expanding vaccine access. The details for this are still being worked through. And we're hoping to get some more clarification out to all of the practices in the coming weeks. But I think it is safe to say that you can expect that there will be some option available for expanding access to your patient population. So I hope that helped answer your question, Simone. And then Margaret, there's a couple questions in the chat that I think you might be able to help answer. The first one from Simone is there an ICD or diagnosis code list that can be used to identify the high-risk patients?
I have not seen anything about that, but with it being so new, it may not be out yet.
Okay, thanks. And then there is a question about if someone received a J&J vaccine, are you supposed to give them either Pfizer or Moderna? And Margaret, would you like to just answer that as well?
Yep, at this time, we're not, I'd actually have to look up the recommendations for that. Sorry, Megan.
Okay, yeah, and you can look at the interim clinical considerations, but from what I've read, I don't think there is a recommendation for someone who received J&J. But yeah, I would have to double check as well. Any other questions or comments? Yeah, Heather Scales wrote in that that's my understanding as well. Yeah. For J&J. I don't think that there's any recommendation from the ACIP to move between brands. Yeah, thank you, Heather. That was something else. The science is behind right now since J&J came out later. So they just need a little bit more time to gather the data. Barbara had a question. Any update on the state of Vermont setting up booster clinics utilizing the National Guard? Margaret?
Yeah, so for the immunocompromised, as of tomorrow, all of the National Guard clinics that are public clinics that the health department has will be able to start vaccinating anyone who falls into the immunocompromised category. For the booster doses in September, we're currently coming up with a plan on how to support that, and we realize that we're going to need to have larger clinic locations from what currently exists. So a plan is being worked on now, and we'll have more information to share soon, we hope.
And Jim, I saw your hand popped up.
Yeah, thank you. Just in terms of that last comment, it sounds like when the boosters roll out that it's going to be kind of more en masse rather than age staged, like the first vaccination rollout. Am I reading that right? Or are you planning, okay, immunocompromised first, then the 65 plus, then the 55 to 65, as we did initially?
So it should follow some of what was done initially, but I think the guidance we've gotten so far also mentions 8 months since their second dose. So it'll also be based upon that as well.
And just one more question to follow up on that. In terms of the attestation, right now it's self-attestation for the health conditions that allow you to go and get a booster. Is it self-attestation for the date in which you had your initial dose as well, so that the 8 month, so that it blocks out the 8 month window?
Yeah, we don't have an answer to that until the guidance comes out, but it should be similar. We just don't know exactly until we get the guidance from CDC, FDA, and the ACIP.
Thank you, Margaret. Yeah, the 8 months and the September 20th is just what the planning right now is based on. We're really still waiting on all of that official information to be released, where it's included in the interim clinical considerations, and all of those questions will be answered once that happens. Jessica, I saw your hand pop up.
Yeah, I'm just wondering, I know you said you guys are still working on some plans for the co-funding of flu and COVID. I'm wondering if you guys have any details yet to share, or, we're in full swing planning for flu, and we're also a resource for the COVID vaccines. I'm just trying to understand if you guys have any envisions of allowing this to be in VAMS and TVRS, if you think you'll be doing any type of contracts that would allow us to do both for any patients and maybe get paid on a per day basis. And then kind of my last question around that, last year, we weren't able to offer state vaccines to patients that weren't attached to our facility, which is very unlike COVID. Obviously, we're vaccinating anybody who, they don't have to be attached to our practice or not. Is there any functionality to be able to offer flu and COVID to any patient and not restrict our state supplied flu vaccines to just the patients attached to our facility?
Thank you, Jessica. That's a lot of really, really good questions. I think,
Sorry.
oh no, it's great. Those are all really good questions. I'm going to start with the first part of your question, which is about the funding. Unfortunately, we don't have any additional information about it right now, but I can tell you that it's not going to be like a contract. It's going to be very similar to the funding that I'm discussing here. Is going to be very similar to what was done last year, where it's ideally going to be a simple grant application process for more defined activities with a cap and a process that is yet to be determined. So not necessarily a contract piece with dealing with VAMs and all of that. And then I saw Karen unmute, but I think what she was probably going to say is that you are able to administer flu to those outside your patient population in a very similar way as that you do for COVID. The issues and the challenges that come up with that have to do with billing and working with your system to make sure that you are billing properly. And then making sure if you're not putting it in your system that those shots get into the registry. If you're administering outside of your patient population, those sort of built-in systems may be a challenge. But Karen, was there anything else you wanted to add?
No, that's exactly right. There is not a restriction on state-supplied flu vaccine being limited to your own patient population. There also might be some other rules around not all practices are participating in the adult flu program. So it may be issues with if you're using hospital supplied vaccine for adults and state supplied vaccine for pediatrics, that might have caused some confusion and all, but we don't have a restriction for only your own patient use.
Okay, that's good to know. So we're, as a hospital, able to use the state supplied flu vaccines in our COVID clinic? Does that, I can't use currently, I can't use state supplied on our inpatients. I don't believe, or we aren't doing that. And only some of our practices are signed up.
Right, hospitals are not eligible to enroll to receive state supplied flu vaccine, but your practices are. So we supply primary care sites. So your individual practices can receive state supplied flu vaccine, but the hospital does not.
Okay, Karen, could I call you maybe after to talk through that a little bit more?
Sure.
Thank you.
Thanks so much, Karen. Then Margaret, Jody has a question in the chat of, will we need to wait 2 weeks between flu and COVID vaccines?
I would have to look that up and get back to you. I'm sure that that's been the guidance for that's out there. I just I don't know it off the top of my head.
Yeah, and,
I looked it up at the CDC just yesterday, and their website has a good block about not being that you can give them at the same time. There's no reason you can't give COVID and flu together. But you can look at you can send out an official thing if you want. But I did look it up on the CDC yesterday because we sent it out to some providers.
yeah, and Heather dropped the interim clinical considerations. Again, I can't highlight enough how valuable this resource is. It's gotten bigger and bigger over the months, but it's organized really well, and it answers a lot of questions. It's a very nuanced document. But yeah, so we, thinking about running flu and COVID clinics simultaneously is something that we're hoping to get resources out about specifically. Are there any other questions? All right, great. I think I might have been chatting and muted earlier, so I apologize if there was a lot of silence. So thank you again to everybody. These will all be posted online shortly. So all the links will be available, and please feel free to reach out to our program if you have any questions. So thank you again for joining us, and a meeting invite will go out, or an agenda will go out for the next one next week, which will be in 2 weeks. So thank you very much, everyone.